Uh, no, just I mean, just to in all seriousness, Nancy put a lot of effort into this. I think she is awesome, and she would be a great resource to all of you guys going forward with respect to not just ventilator management, but critical care. Because I think it's, at least to me, it's a fascinating field of medicine, and she is very much drawn to it and is passionate about it.
Thank you. Okay. Yeah, thank you. And I'm going to share my screen. Okay. So, okay, I'm not going to go the first, but intro to ventilators. And first off, I told you guys in the email that we're going to be doing a quick pretest to see if these lectures are actually teaching the material that we want to get across. So we're going to do a quick Kahoot like we did during our presentation. And if you could, I'm going to show you the exact, it's 10 questions, multiple choice. I'm going to show you the exact same test at the end of the lecture. So if you could keep your username the same for both, so I could like track answers, that would be great, but you don't have to listen to me either. Okay.
Hey, sorry, Nancy, Dr. Jafari, just wanted to ask you, for people who are going to watch the slides, would you want to recommend that they take it also before they watch the slides, or is that not possible?
I'm not sure what you're asking.
I don't think they can take it from a recording. Like I have to be.
Oh, later on. I see.
Yeah.
Yeah, I think the purpose is sort of getting a delta. So I think it's important to get the pre and post, but it would be up to Nancy to keep I guess, the code link live if people can't use it in like offline, essentially. I don't know. We can decide about that. But just so everyone knows, we're not tracking your performance, but we are interested in seeing how helpful this is. So you're essentially are participating in a sort of a study, although we haven't formalized it yet.
Sorry. 1 second. There's 12 over here. There's a couple more seconds. Okay. Go ahead and get started. So the answers, I'm not going to show you the correct answer in the pretest. Instead, it'll just pop up as a poll of what you guys chose. And then at the end of, during the post test, we can go over the correct answers and if you guys have any questions or anything like that. Okay. All right. Everyone, okay. I'm going to go ahead and get started. Twenty seconds. Okay. I know it's kind of blurry, sorry guys. Okay, last one. Okay, awesome. All right, you guys are so smart. Okay, so we'll go over those at the end, and all the answers to all those 10 questions, if I do my job correctly, should be in this presentation, and then we can definitely go over them at the end as well. Okay, so and if any of you have questions, I don't think I can see the chat, so please just jump in. And Dr. Jafari, please, if I say anything wrong or if you have anything more to add, please jump in as well. Okay, so we did that. So the objective for today is going to be pretty simple, kind of like a pilot of how these sessions are going to go, and also to be able to look at the screen and be able to report on rounds what is going on. So not seeing this and freaking out, but being able to really see like a general idea of what your patient is experiencing. Okay. So of course, we're going to start off with some normal physiology. I'm not going to go as crazy as every single lung pulmonology definition. So I thought I would simplify it to these two graphs here. So I'm going to start with the figure on the left that we've seen, just for the sake of review and just so everyone's on the same page. And for me, I'm going to define kind of all the basic terms. So bear with me if you already know all this, and it's a review. So on the left, we have a flow volume loop, which is going to show your flow of air during a breath. So if you remember, you're going to start from point A, your x-axis is your volume, and your y-axis is your flow in liters per second. So a breath starts at A, you inspire, and then as you go up to point D, passively exhale and repeat for each breath. Okay, and on the right side, this is like the classic picture we all memorized for step one. I'm going to take the liberty of simplifying this down a little bit to just tidal volume, because that's going to be one of the more important parameters for this presentation today. So your tidal volume is going to be the amount of air going into your lungs when a patient is breathing comfortably. And if you multiply that by how many breaths they're taking in per minute, you're going to have a minute ventilation. And that's going to come in handy later on because it's a pretty important concept to gauge whether the patient is strong enough to breathe on their own, whether they still need a mechanical ventilator. So these are just kind of the key definitions that I wanted to pull out here. Okay. And lastly, another definition that I wanted to point out is the vital capacity, which is going to be your volume from your maximum point of inspiration, as much as you can breathe in, to your maximum expiration, as much as you can breathe out. So that's going to be important, for example, if you want to see if a patient is ready to come off of ventilation, kind of seeing how much they can do on their own, how strong their lungs are, and kind of use that to gauge how they're doing clinically. Okay, so how does this actually translate to a ventilator screen? So on a ventilator, you're going to see three waveforms on each. You're going to have your pressure waveform, your flow waveform, and your tidal volume waveform also. Basically, I just wanted to have this picture to correlate the physiological part with what you're just going to see numbers and waves on a screen. So I'm going to talk about pressure in the next slide, so hold off on that for a second, but your flow loop here is going to be translated into a flow time waveform, and then your tidal volume here is this waveform at the bottom. And also, I just, you guys did pretty well in this on the pretest, but in terms of 4 numbers that you classically use for port vent settings, for example, volume AC is going to be one of the more common ones that you see. And the 4 parameters that you want to keep in mind when you're doing this are your tidal volume, in the case of volume assist control, respiratory rate, peak, and FiO2. And just so we can get into the habit of learning how to present these numbers during sign up, for example, in the upper right-hand corner for each ventilator screen, I'm going to have these kind of 4 numbers laid out for you in the upper right-hand corner. So just keep an eye out for that. So next, I wanted to go into the pressure waveform. One second, your guys' faces are great. Okay. So this slide is kind of a lot of definitions, but I just want to walk through the waveform and then we'll get to each definition individually. So just really simple, starting off, when a patient needs a breath, a ventilator is going to administer air, correct? Just ignore every other function of a ventilator for now and just think about a machine pumping air into someone's lungs. As this happens, as you push air into these lungs, your pressure in this system, this closed system, is going to increase with inspiration. Ignore plateau pressure for now, and they're going to passively exhale, and that pressure in your respiratory system is going to decrease. So that was really simple. You probably didn't need me to explain that at all. So let's look at plateau pressure for a second. So let's say when I'm ventilating a patient's lungs, one thing that I want to be aware of is making sure I don't explode their lungs with the amount of air that I'm pumping into it. And one way to think about that is what are the actual alveoli experiencing? What kind of pressure and what kind of environment are they going under? So if I wanted to measure the pressure all the way down in the alveoli, instead of sticking a tool or instrument all the way into a patient's lungs, we do something called a plateau pressure. So a plateau pressure is at the end of inspiration. So the machine delivers the air, and at the very end of inspiration, we're going to stop. So there's no more air going into your system, your respiratory system. And because of this, without your air constantly flowing in, everything kind of equilibrates across the entire system, if that makes sense. So you have a closed loop, nothing's going in, nothing's going out, and the air just kind of settles equally across your entire system. So a pressure that I'm measuring from, for example, the patient's ET tube will equal the pressure that their alveoli are experiencing. So I can use that as a way to kind of test what is going on deep down inside this patient's lungs. And that is what's going to be called the plateau pressure. Now, the difference between these two pressures, your maximum pressure that you experience during inspiration and this plateau is going to be a representation of your airway resistance. I know that's a little bit hard to wrap around, so I'm going to use this poorly drawn curve to kind of help out with that. So for example, if let's say your patient's ET tube is kinked, and when the machine is like, okay, I got to give this breath, and it's going to start forcing air into this compromised tube, into this tiny hole of the tube. So your pressure is going to be like insane during inspiration because your tube is compromised. However, if I stop that flow of air in and everything equilibrates, not a lot of air actually made it in. So my plateau pressure is going to drop way down because the pressure actually inside my lungs, inside my respiratory system is not that high. So because this drop is so huge, that kind of gives you a tip off like, hey, something's wrong. This is a pretty big difference between my peak and my plateau, which means there's something contributing to airway resistance in this patient. So this difference is just another way of signaling, hey, might want to check out the patient, see what's going on. This as a side note, this lecture is more of like the mechanics and the very, very basics of things. And then we can go into like troubleshooting or different types of things in a future session if that's what you guys want. But just for like the scope of this lecture, I wanted to say that. Okay, cool.
Can I interrupt for 1 second, Nancy?
Yeah, of course.
This was perfect. This was very nice and clear explanation. Just one thing that I like to reemphasize when we go through this waveforms is it's a little bit difficult to wrap your head around both pressure and flow at the same time because we have an intuitive sense of pressure, right? We understand pressure because we can sense it. The flow is a little bit different, but it's actually very important in your ventilator settings and how the patient interacts with the ventilator. The plateau pressure essentially works on the principle of the law's gases that says that if you have no flow within a closed system, the pressures should become equal. Because if there's a difference in pressure, then you would still have flow, right? So if you close, as Nancy was mentioning, if you close your valve on the ventilator after the full breath is delivered, then you have no flow. Hence, the pressure inside the ventilator, which is a closed system with the patient, should be equal to the pressures that the alveoli are experiencing. Now, remember from the histology books, the alveoli are thin-walled, very brittle. On the other hand, the main airways, the trachea, has essentially cartilage in it. So it's very resilient in absorbing pressure. That's why we're more worried about plateau pressure as opposed to the peak pressure when we're trying to figure out, are we protecting the alveoli abnormally high pressures during the cycle of the ventilation. So if you think about no flow equals pressure being the same across, it makes a whole lot more sense every time you look at plateau pressure and trying to like conceptualize it in your mind. Okay.
Thank you. All right, and then the last definition I wanted to just point out on this graph before we move on is, so this downslope here is going to be as your passive exhalation, right? So as you can see in this example that I pulled, this curve goes all the way down to 0. Let's say it didn't go down to 0. Let's say it went to 5, which means that there's a pressure at the end of expiration, or your peak, your positive end expiratory pressure. This is a pressure that can be used to split alveoli open. It's going back into your airway to really help you help keep those alveoli from collapsing. And this is important because, I mean, the machine will tell you, hey, your PEEP is 5, 10, 0, whatever, but you can tell from the waveform if this PEEP is gradually increasing or if it's something that you didn't intend for the patient to be experiencing. That's just another tip off that something is going on with the patient. Okay, so those are all the definitions I wanted to talk about here. Any questions before I move on? Okay. All right. So next, we're just going to jump into the different modes of ventilation. So the main thing, so there's a lot of different types of companies, models, with different capacities and different levels of sophistication. So this is a simplification of what you're going to see, but basically the most common type is going to be assist control ventilation. And within that umbrella of assist control, you can control either your volume or your pressure. So hence you can have a volume assist control or a pressure assist control based on what you are setting into the machine. And the machine will respond accordingly. Past that, the rest are kind of tweaks and combinations of the mechanics of the ventilator to really make it, to make each of these unique. I'm going to talk about some of them because I think they're worth mentioning and you might see them on your rotations. I'm not going to talk about APRV and HFOV, but they exist in case you see them. But I think the ones that we'll be hitting in this lecture are the important ones. Okay, so just as a layout of how this lecture is going to go, for each mode, I've divided it into 4 different categories. What you set, what the machine will do for you, what kind of patient it's good for, and potential downsides or problems with each mode. Big disclaimer, the who it's good for, the approach to ventilators, it's not like a one-to-one kind of thing. It's not like, oh, this patient has this disease process, I need to put them on this mode of ventilation. It's definitely very patient dependent. You really just have to watch at the bedside, see if they're comfortable, see how they're doing, you know, draw your ABGs. So this is a very rough idea based on like ideally how the physics of that ventilator is going to correspond to the physics of the physiology of the patient. But clinically, it's not going to be like 100% correlation. So we can probably like comb that out into finer details in a later session, but for this one, it's just very rough idea categories. And another thing that I also thought would help in organizing the different type of modes is kind of like a spectrum. So like big point picture ventilator, help the patient breathe, right? But how much am I helping them breathe? Am I taking over the work of breathing for them, which is going to be the most support? Or am I kind of just hooking them up to a nasal cannula and supporting them that way? So there's a spectrum. It's not really binary, they're on a ventilator or they're not. There's different modes that can help you adjust based on the patient's strength and the patient's ability to breathe on their own. So you can find the ventilator mode that's best for them. Okay, all right, so let's get into it. First off, we're going to start with the most common thing that you're going to see, which is volume assist control. So in this setting, you are going to set the tidal volume, how much volume of air the patient's going to receive. And with most of these modes, you will be setting a respiratory rate, a PEEP, and an FiO2, how much oxygen is going in that air. And as a response, what the machine is going to do is provide as much pressure as required to deliver that volume of air into the patient's lungs. Now, this pressure is going to depend, right? Because you didn't set it, the machine's just going to do what it needs to do to reach your desired tidal volume. And this is going to depend on the compliance of the lungs. So let's say my lungs are super fibrosed, I have restrictive lung disease. This is going to be a very low compliant system, right? So more pressure is going to be needed. I really need to shove that air in to reach that volume that I want. On the other hand, if I have like emphysema or my lungs are very compliant, it's going to take less pressure to get that same amount of volume delivered into those lungs. So the pressure that you see on as a result of the machine delivering that tidal volume is going to depend on the physiology of the patient and whatever disease process is going on. So as you can see, too much pressure is probably bad. You don't want to, again, explode their lungs out. Barotrauma is a thing that we want to avoid. So this kind of ventilation is good for patients who can achieve that tidal volume with a low pressure. So patients with high compliance with obstructive lung disease like COPD or asthma. So that's kind of a bigger color, like volume assist tends to be for those with high compliance. And also, on the other hand, this can have some potential problems. The thing with volume assist control is that every time a patient tries to take a breath or every time the machine delivers a breath, they get the full tidal volume. So if I say I want, 0.59 liters of air into this human, they are going to get that entire 0.59 every time the machine decides that it's appropriate to do so. So for example, if your patient becomes tachypnic and starts triggering a ton of breath without really properly inhaling and exhaling, your machine is just going to keep shoving that 0.59 liters with every trigger. So this can obviously lead to air trapping. It's not good for the patient's physiology or their breathing. So this is a potential downside. Another thing to look out for is if the patient does have low compliant lungs and they are reaching very dangerous pressures, then this may not be the best mode of ventilation for them, because you're not kind of in that sweet spot where you're delivering the volume, but at a pressure that's safe for their lungs. Okay. Any questions?
Can you explain what you mean by triggering the breath?
Yeah, so I didn't want to get into this, but so basically, I'll explain more in the next slide, but when so the patient is connected, and there's a couple ways that the machine can tell that a patient wants to breathe, either a change in pressure or a change in flow. And you can, I believe you can set that to what you want based on like the patient's physiology. Like if they have ARDS or something, then it's going to be different. But let's say the patient tries to take a breath, there's going to be a negative pressure, and the machine will see that and be like, hey, this patient is trying to breathe, and then help them by delivering that full tidal volume. Or if there's a change in flow by the patient trying to inhale, the machine's going to see that and be like, okay, this is a breath that I need to help with. Does that make sense?
Yeah, it makes sense. But like the idea here is that you try to do a breath and then it helps you versus it controls when you breathe.
Yes, you're one step ahead of me. So let me, yes, let me just jump into, I'll come back to that, Bilal. Is that okay?
Bilal, ventilators have two ports, inhalation and exhalation ports. And in both of them, there is a trigger sensor for pressure and there is one for flow. So as Nancy was saying, there's literally a setting on the ventilator that you say flow trigger of this many liters per minute, I want to give the breath. So if the ventilator is constantly listening, and as soon as it hears that the patient is triggering the vent, meaning trying to inhale and create a flow that is not generated by the machine understands it and knows that the patient is trying to breathe. Make sense?
Makes sense.
Okay, cool.
I had one question. So is it possible for you to trigger a cancellation of the supported air? Like, would you be able to sort of autonomously breathe and then the machine would stop?
Yeah, so there are instances where the patient will try to breathe while the machine is giving them a breath, but in this mode, the machine is going to deliver that breath no matter what. Actually, I will explain it when we get to this slide, and then after that, if it's still not making sense, we can come back to that. Is that okay with you guys? Is that okay, Philippe?
Yes, thank you.
Yeah, okay, cool. Yes. So before I jump into the actual ventilator screen and address all y'all's questions, I just wanted to go through the pressure and flow form in just like a theoretical sense before. So on the left, we have your pressure time waveform for a volume assist control. Same thing, you start off with your end expiratory pressure, inhale, passive exhalation, repeat. On the right, you have your flow versus time waveform, not your flow volume loop, which I showed you at the beginning, a little different. During inspiration, your machine will deliver this flow of air to get your tidal volume. And throughout the course of inspiration, this is going to be a constant flow of air. The source I got this from kind of described it like drinking from a fire hydrant. So in some ways, this can be uncomfortable for the patient because as soon as they trigger a breath or want to breathe, they literally just get like a blast of air for the entire time of inspiration. So keep this in mind. We'll compare it to other modes later in this lecture. But after that, you have passive exhalation. Okay, so now the real ventilator screen. I'm gonna start off. So our three waveforms in every ventilator, we have pressure, flow, volume for every time. The number, so this, before I go into that, as I mentioned, there are different types of companies and models. These are ones that I pulled from the internet. This is Avia, I believe, which is the one they use at the MICU at North Shore, I think. And then I'll try to incorporate other examples like Maquette, which is what they use in the SICU at North Shore. There weren't a lot of patients on ventilators, which is a good thing. But just keep in mind that not every machine is going to look like this. For this model, you have the three waveforms, and at the bottom of the screen, you're going to have the numbers that you set. So you are setting all of these parameters here. And as promised in the upper right, this is how you would report it. So I have my tidal volume here, 590, my respiratory rate of 12, my PEEP of 5, and my FiO2 of 30%. So around, I'd be like, this is a patient on volume AC, tidal volume 590, respiratory rate 12, PEEP 5, FiO2 30%. And what is also important here is that the numbers on the left side of the screen on this model, sometimes they're on the right, but basically this is what your patient is experiencing. Because even though I want to give a patient a set amount that I think would be good for them, they're obviously not going to listen to that exactly, right? And if something is wrong, you can tell if there's huge discrepancies between what the patient is experiencing here and what you see down below. I'm not going to describe every single number on these for you guys because it's kind of like apps on like a phone, if you will, like based on the machine, you can decide which numbers you want to see, and you can like kind of customize it. So going through every single number is not like the point that I want to get across here, but if there's an example, then I'll definitely point it out for you guys in the screenshots here.
Nancy, hold on for 1 second.
Yeah.
Can anyone, not you, because I know you know the answer, can anyone tell me why the P plat, which is the plateau pressure on the left column, is left with a few stars instead of an actual number? Can anyone take a guess? Don't be shy. There are no wrong answers.
This is just a guess, but is it you have to press the button for the inspiratory hold for it to calculate it?
Bingo. Yes, you remember we said we have to stop the flow. So that is an active measure. The machine doesn't do it on its own because, as you can imagine, it's actually dangerous. Not only it stops the ventilator from delivering breaths, but it can also cause a lot of abnormally high pressures. And we do it for very brief periods of time, 2 to 3 second pauses to measure the plateau pressure, and then we'll step back. So that's why it's not being measured second by second. You actually have to do something on the machine to be able to derive that plateau pressure. So once you hit the inspiratory hold, it actually closes the valves and allows for the pressures to equilibrate across the system. Very good.
Yeah, Victoria. Okay. So the next thing I want to point out, this screenshot is actually from a YouTube video that I found, which is also kind of like an intro to vents targeted towards med students. There's a link in this PowerPoint somewhere. So if you guys want to check that out, if that's a better learning for you. But basically, one thing I want to show is the yellow waveforms versus the red waveforms. And I don't see Corey on here, which means none of you are colorblind. So the yellow waveforms here are breaths that are initiated by the patient, and the red waveforms are breaths initiated by the machine, the ventilator. So kind of, Philippe, let me know if this long spiel answers your question, but basically with assist control, this is like the highest level of support that you can provide for a patient. So if the patient is trying to breathe on their own, they might not be able to take a full breath successfully, or they might trigger it and stop. So either way, your machine is going to deliver that full tidal volume no matter what. And as Dr. Jafari mentioned, the machine's kind of always listening. So like if a few seconds pass by and the patient hasn't triggered their own breath, then the machine is going to be like, okay, this is my time to deliver that tidal volume now, because the patient's not doing it for their own. So kind of what's happening here is like patient triggered, patient triggered, patient triggered, and the machine's like, oh, I haven't heard anything, let me give them a breath. So those, the colors are going to differ based on like which model, of course, you have. But this is kind of the difference between the two waveforms. So Philippe, I guess it is possible that in the middle of delivering this, the patient could try to trigger their own breath, but in this mode, I don't think it would affect it because it's kind of like a pass-go situation. Like as soon as the machine wants to, it's going to deliver the full tidal volume. Is that correct, Dr. Jafari?
It is. I think Philip, maybe I've misunderstood him, but I think his question was a little bit different. Now, if I understood him correctly, he was asking whether there's any possibility for the machine to cancel that breath that the patient is initiating. Am I right, Philip?
Yes.
Yeah. So, okay. So I can hours about this grand topic of what we call patient ventilator dysynchrony. it's a big topic. There are books, literally books written about it. But very briefly, it's all the interactions between the machine and the ventilator. And the short answer to your question is there's almost nothing on the ventilator that you can do to stop the patient from doing what they want. That's why every patient who is on a ventilator is also receiving some form of sedation and anxiolysis. Okay, if you don't, so that's your dial. That's how you prevent the patient from triggering the vent or taking a patient-initiated breath, as opposed to having something on the vent that can do that. There are things that you can do on the ventilator to prevent the patient, but they're just incredibly uncomfortable for the patient. So if the patient is not sedated, they would not go with the ventilator, so to speak. They would do what they want. That's why it's so important during rounds when you're in the ICU and trying to explain to the team what you saw on the ventilator to also mention the sedation status, how sedated the patient was, how comfortable they were looking at the ventilator, and what medications they're taking at what rates. If it's an infusion, what was the rate of the infusion? If it was an intermittent IV injection, how frequently are we giving it? Okay.
Yes, thank you.
Okay, awesome. And before I move on from the slide, just to hone in on that point that what the patient experiences might not be what you set. This, I know it's kind of blurry, but this here is showing the exhaled tidal volume. So I set here that I want them to get 0.59 liters, but here it says the patient is breathing out 0.64 liters. So this can happen if the patient is like pulling in more air on their own, or if there's another source of air like a chest tube or something like that, something else that's going to add more air than what is coming from the ventilator. There's different scenarios, but example, if like the tube is too small and the patient is breathing around it. So there's a lot of things to rule out if you see like a huge discrepancy. Like this were like some insane number, like 0.8 or something. But otherwise, it's just my main point in this case is just to say, don't forget to check the left side of the ventilator. Okay. And all right, so that's all for volume as control. If no one has any questions, we will flip over to pressure. All right, so this is now pressure assist control. You're still under the umbrella of assisted control, the full amount that you can do to help a patient breathe. And instead of controlling the tidal volume, instead you're going to control the pressure. So I guess the way I kind of think about it is that, let's say you were on volume control for a patient and their lungs were just not compliant enough, and you were reaching pretty dangerous pressures when you were trying to give them this full tidal volume of air. So if that's happening, what you can do is kind of switch over to pressure and say, you know what, I'm going to control the pressure that the patient is experiencing so it doesn't get dangerous for them. And whatever the tidal volume is, that's going to be up to the machine. So in this case, what you are going to set here is the inspiratory pressure and inspiratory time. I think these definitions are better explained with a picture, so I'm going to show them on the next slide. And then also the typical things, respiratory rate, PEEP, FiO2. And what the machine will do, it will increase the pressure that you tell it to. Okay, let me reword that. So if you start at a baseline pressure, you say, I want to increase the pressure this patient is experiencing by X amount. And the machine will say, okay, increasing by X amount, and whatever tidal volume is generated by that machine generating that pressure is what the patient is going to receive in their lungs. So, and then again, I'll show this on a graph on the next slide, but what it's good for, it's a little bit more comfortable for the patient, which I'll show with the flow graphs. And also, if they're not doing well on volume control, you can try switching over to pressure, see if they do a little better with that, if they're more comfortable. So potential problems, obviously, one of them is that you are no longer in control of the tidal volume. And this can vary based on the respiratory compliance, which can change pretty quickly in the ICU. For example, if someone gets a pneumo, if they're slowly building up an effusion, these are all things that are going to change the compliance and are all things that are going to affect your tidal volume to the point where they may not be getting enough air. So potential downsides of pressure assist. So this is what I was talking about here. The ones in blue are the ones that you will be setting. So I set my PEEP, kind of like my baseline expiratory pressure. And what I mean here is that you're going to set this difference here, the inspiratory pressure. So let's say my PEEP was 5, and the machine, I'm going to say I want an inspiratory pressure of 20, and the machine will raise that pressure by that much. And also the inspiratory time, which is how long that machine is going to hold when it achieves the inspiratory pressure that you set. So the peak area pressure, you do not set the peak area pressure in this mode. All you're setting is these two, and in a situation where things are working great, there's no complications, your peak airway pressure here, the maximum pressure, will equal your inspiratory pressure plus your peak. Does that make sense? I feel like this was kind of hard for me to wrap my head around. Okay. So this is the pressure time curve for a pressure assist control. When I mentioned that this might be more comfortable for the patient, this has to do with the way the machine delivers that breath, which you can see with a flow time curve. So if you remember, for volume control, I mentioned that this book described it as drinking out of a fire hydrant, right? It's just constant flow of air throughout all of inspiration. On pressure assist control, on the other hand, you're going to get a decelerating inspiratory flow. So as your lungs fills with air, the flow will decrease, kind of. So kind of just slowly filling your lungs to the brim instead of blasting them all at once. And this is going to correlate to just the patient being more comfortable. So this is one of the advantages in this scenario. Okay, so actual ventilator screen. As promised, the numbers on, so of course we have our 3 waveforms: pressure, flow, tidal volume. Numbers are the bottom of are what we are setting. Sorry for the colors here, but the blue is what is going to be reported on sign up, for example. So this is a patient on pressure assist control with a inspiratory pressure of 20, a PEEP of 5, respiratory rate of 20, and an FiO2 of 21%. And of course, you are setting the inspiratory time here. So let's look at the left side of the screen. So in this scenario, as you can see, my PEEP of 5 plus my inspiratory pressure of 20 is actually equaling what the patient is experiencing of a peak pressure of 25. So here, this is pretty good. I don't think that there's anything else contributing, causing more pressure in the airway. If this were like 35, I'd be concerned. I'd want to check the patient, see if there's anything going on. But in this case, this is looking good to me. And another thing that is good to know is how to calculate the expiratory time in the scenario. So we take our rate here. I just wrote up the calculation here, but let's say you say for during this minute, I want the patient to take 20 breaths. So the time for each breath is going to be 3 seconds long, 60 divided by 20. And so one breath, inspiration and expiration, is going to take you 3 seconds. Now I am setting the fact that inspiration, the amount of time that the machine is going to hold that inspiratory pressure for, is 0.40 seconds, which means that 3 minus that is going to be my expiratory time, 2.6. So why is this important? So you also want to make sure that when a patient is breathing, that they're fully exhaling. They're not, you want to give them ample time for them to move that air in and out. Because if your expiratory time is too short, for example, and then the next breath starts, that's just going to lead to a lot of problems. So this is just another parameter to keep in mind and something that you can calculate. It's also here very tiny. Okay, so
this is Nancy, this comes from a Draeger machine. As you said, at the bottom, it actually points out that you set it to 0.4 and then 2.6 based on the respiratory rate of 20 would be your expiratory time. In some machines like Avia, you only set, and so another way of saying all these things that you said is to say I to E ratio is what? So it essentially is, so for in this particular patient, the inspiratory is 0.4 and expiratory is 2.6. So I to E ratio would be 0.4 divided by 2.6. And it may not register right away with you when you look at those machines. So it's a little bit, it's less intuitive than these machines when they actually give you seconds. At the very bottom, you see it says 1 divided by 6.5. That's the I to E ratio. So this machine, the nice thing about this machine is it actually gives you both versions. So you can look at inspiratory time, expiratory time, or you can look at I to E ratio. In normal people, just if you can like pay attention to your own breathing, like as we're listening to Nancy, it's like 1 to 2, 1 to 3, right? So you take about 1/3 of the time to take a breath in, and the rest of the 2/3 or maybe 3/4 to exhale that. So the exhalation, because it's totally the result of the recoil function of your chest wall, it is not active. It takes a little bit longer, and you don't. It's a very energy efficient process because you don't need to do anything. You just wait for the recoil features of your chest wall to exhale to push the air out, and then you would get ready for energy consumption part of the respiratory cycle, which is the inhalation. So your goal as the intensivist should be to mirror that for the patient, so it would be comfortable for the patient. But additionally, you run into certain patients, especially non-compliant lungs, or if you have really bad air problems, that having too short of an inspiratory time might run into big trouble. You will, if you're not allowing the patient to exhale long enough, on the other hand, in asthma, COPD, all the obstructive lung diseases. So you shorten the exhalation time at the and allowing for the inspiration to be longer, then you might run into breath stacking, what we call breath stacking, or air trapping, the other name for it. Make sense?
Thank you. All right. So next mode of ventilation. So now we're done with the assist control umbrella, and this is now the pressure regulated volume control. And the way I like to think of this is if you took the best of volume control and the best of pressure control and kind of just smush them together. Because as I mentioned with volume, you're kind of worried about delivering a tidal volume and generating too high of pressures. In this mode, the machine will deliver that tidal volume at the lowest possible pressure for you. So you are setting the tidal volume, the inspiratory time, respiratory rate, PEEP, FiO2, and the machine will do it, but it will also keep in mind that it doesn't want to just do it at any pressure possible. It's going to do it at the lowest one. So you avoid barotrauma. What it's good for, best of both worlds. Potential problems, the patient and the vent can get out of sync. For example, if the patient's demand increases, for example, then all of a sudden the machine is going to be like, wow, like this patient is just sucking this air in. I barely have to generate any pressure to deliver this tidal volume. And then that pressure is going to go lower and lower and lower to the point where the machine isn't even helping the patient breathe at all. So it's kind of, it's the best of both worlds, but also not foolproof in terms of just clinically what's going on with the patient. One question I had is like, why are we just not doing this then? And the reason is just levels of sophistications of machines. Most of the ones you'll see are with volume control, and this mode is reserved for kind of more advanced ones, fancy ones, I guess. But I think I have a picture of this one from our SICU, which I'll get to. Yes. So this is a picture from the SICU on a patient who was on PRVC. This is a maquette ventilator, and pretty much the same layout. You have your pressure, flow, volume waveforms, and the settings at the bottom. So I have a tidal volume of 500, a let's see, respiratory rate of 16, a PEEP of 8, and an FiO2 of 40%. And then now instead of the left, I guess it's on the right, but what the patient is experiencing here. Any questions about this mode? No.
So this Servo-U maquette machines are only, I think, 10 years old. As Nancy mentioned, the reason that we're not putting everyone on PRVC is we just don't have the technology in all these ventilators. Believe it or not, some of our ventilators are 20, 30 years old. So some of them just don't have the brains for it. As Nancy was mentioning, the machine needs to be fast enough to make decisions, sophisticated enough to measure flow and pressure at very short intervals, literally milliseconds, during the delivery of the breath, to decide what to do with the flow and pressure. So it's just that these are very sophisticated machines, and now they have the ability to do all these things, hence the availability of PRVC as a mode on them. But if you go to older generation machines, they're just not available. In fact, in our surgical ICU, the initial mode of ventilation for everyone is PRVC because we all have maquettes.
Awesome. All right, on to the next one. So the next one we're going to talk about is pressure support ventilation. And I'm going to just remind you guys of that scale that I showed at the very beginning. Assist control being the most amount of support, and then you can obviously have less support if the patient is able to do some of the work on their own. Pressure support is kind of on that lower end of the scale. The patient is setting their own breathing rate, they're triggering their own breath, and all you're doing is kind of just adding a little bit more oomph so that they can breathe fully with this pressure support ventilation. So you are setting the amount of pressure support you want to give them, a PEEP, and an FiO2, and then the patient basically does the rest. What this is good for, it's good for seeing if they're kind of strong enough to start coming off the ventilator. It's good for seeing if like they're ready to breathe on their own. You can use it with CPAP and other things. It's not like a new mode of ventilation. It's just like kind of a very fine mode to help the patient the best. It's not just letting them off with just CPAP or putting them under too much sedation on a ventilator. It's a nice in between. So you can use that to kind of wean them off. Potential problems, if they're obviously not strong enough, this mode of ventilation is not to help them with the respiratory effort. It's not going to take over any work of breathing for them. So if they're not at that point yet, then this mode is kind of out of the question. One thing that I did want to point out, because I got confused, was pressure assist versus pressure support. So just to lay it out for you guys, here it is. Pressure assist, we already talked about it. Under the assist control umbrella, and pressure support is the patient doing most of the work, and you're just kind of giving that extra pressure for them. There's other details here if you want to go through it. But I would say here, so pressure assist, you're going to be setting the respiratory rate and the inspiratory time for them, because the machine needs to know how long it's going to hold the inspiratory pressure for, versus pressure support, you don't really have any of that. And as the air enters the lungs, the flow will decrease. There's no setting for that. It's just really closer to natural breathing. All right. So this is an example of a screen. As you can see, it's CPAP with PSV. Again, not like a brand new mode of ventilation. It's just CPAP. It's your pressure that's there. And then whenever the patient decides to take a breath, the pressure support is the extra help that you're giving them during that inspiration. And as you can tell with this model, all of the breaths are yellow because the patient is initiating all of them. There is not going to be any red ones here. And just for reporting, I have this patient on a pressure support of 10 with a PEEP of 5 and an FiO2 of 21%. Okay. All right, and this is just another version of the same thing. This is the maquette from the SICU, same thing. All right. Okay, and our next mode of ventilation is going to be synchronized intermittent mandatory ventilation, or SIMV. And the reason this is last is because basically if you took all of assist control and pressure support and combine those two together, then you would get SIMV. I think this is best explained with a picture as well, because I'm just a visual person. So I'm going to do that. So basically, if you remember with assist control, no matter whether the patient initiates the breath or the machine gives the breath, you are going to receive that full tidal volume or that full breath, no matter who triggers it. In this case, it does matter who is triggering it. So in the cases where the machine is delivering the breath, it's going to go as if it were just under your normal assist control settings. So as you can see in the red, this is a timed machine breath. This is like, hey, I set a tidal volume that I want, and the machine is going to give that full tidal volume as if the patient was on a volume assist control mode. But let's say the next breath, the patient decides to trigger their own breath. Then the machine is like, okay, I'll back off and I'll switch to pressure support. So instead of delivering an entire tidal volume, it's just going to give you a little extra nudge of pressure to help that patient breathe in more. So as you can see, this is, you can think of it as like a volume assist control, pressure support, volume assist control based on who is triggering that breath. So this is, I like to think of this as kind of like in the middle of the spectrum. You're not taking over all of the breaths, but you're also not leaving the patient to trigger and complete all the breaths on their own either. So going back to these categories here. So for these assist control breaths, going back for a little bit, it's the same thing as an assist control. You can decide whether you want it to be volume or pressure, and the same things apply. So if I wanted to use volume assist, I would set a tidal volume. If I wanted to use pressure assist for those breaths, I would set inspiratory pressure, and then the rest as follows: the respiratory rate, PEEP, FiO2. And then on top of that, because I need to account for the patient-initiated breaths, I'm also going to set a pressure support, how much I want to give them during those breaths. So this is good because it allows patients to kind of take breath spontaneously. As I said, it's in the middle of that spectrum. And potential problems, obviously, if they're not at that point yet, they're not strong enough, even for those few breaths they're taking on their own, they can get fatigued. So you really just have to look at what they need. And let's see. Okay, and this is a screen. So as you can see, this is a pressure SIMV. So this is SIMV, but I'm using pressure assist control for those machine delivered breaths, and then pressure support for the patient initiated ones. Without even looking at this, you can tell from the bottom of the screen, because at the bottom are the numbers that I set. I'm setting an inspiratory pressure, an inspiratory time, all these things that you would normally use for a pressure assist control mode. So you can just tell like that's the one that you're using. And then of course, for PSV, I'm giving an extra help of 8. And as you can see here, these are all red breaths basically. So I couldn't find a picture off the internet that showed both breaths combined, but this is as if you were just looking at a pressure assist control. These are all machine initiated. They're all following the inspiratory pressure and the time that you set. And if the patient decides to take a breath on their own, then you'll see a little blip here of that 8 going up. You would report it the following, the top as if it were pressure AC, so SIMV, inspiratory pressure 15, you have a PEEP of 5, respiratory rate of 20, FiO2 of 21% with a pressure support of 8. Okay, any questions about this mode? Okay. All right, so this is just for your information if you decide to look back. Just kind of like the last 3 slides smushed into a table. Again, keep in mind that this good for row isn't going to be a one-to-one correlation. I just kind of put that in there to help get a better idea of it. And then that is the basics of what I wanted to do for this presentation. I know it's already past 7, but before we get to the post-test, any questions? I think
for the pressure support ventilation, you said that it provides a set amount of pressure with each breath the patient takes.
Yeah.
How is that different than PEEP?
Yeah, so the way I understood this, please correct me if I'm wrong, is that PEEP is like at the end of expiration, that's the amount of air that's remaining, that's the amount of pressure remaining to kind of help my airway stay open. I think Dr. Jafari, you mentioned that all people on a ventilator are going to have a baseline PEEP because they're trying to breathe through a tube and it's very uncomfortable to do so. So giving them that PEEP, that extra pressure, just that baseline is going to help them breathe easier through that tube. Pressure support, on the other hand, is more of a help with inspiration, if I'm understanding correctly. The patient will trigger that breath and I am delivering pressure into the patient to help deliver a breath for them. Whereas PEEP is after exhalation, that's the pressure that's remaining. Does that make sense? Is that correct?
That makes sense.
Okay, perfect.
Yep, that's right. The PEEP you can think of as so in someone who is not hooked onto a ventilator like you and I, we don't have an expiratory pressures. It drops to almost atmospheric pressure. When you're trying to breathe through a narrow tube, as Nancy was saying, it's just a lot more difficult. So conventionally, we always compensate for that. We call it compensation with the tubes and the endotracheal tube, the tubing between your patient and the machine, to just allow for the patient to breathe easier through essentially a straw.
Okay. Any other questions?
I think Nancy, you should go to the post test, and
Okay.
I'm happy to answer any questions after. But I just think this was because it's sort of before and after. We get these questions out of the way, and then we will take questions from the audience.
Okay. Good. Okay. All right. Same thing. If you guys could keep your usernames. Anybody else want to join? No. Okay, that's fine. All right. Let's get started. Okay, exact same question. Oh, great. The answer is peak area pressure minus plateau pressure. Oh, I didn't mean to make this competitive. I'm sorry. Okay, I guess it is now. Nice. This control is correct. Okay, Maddie, person to catch up to. The answer is 0.4. Numbers on the bottom of the screen. Okay. All right, perfect. Numbers on the left. 0.25. Oof, an upset. Okay. Next, inspiratory time. That's when you're going to set during your pressure assist control. 2.6. That's the calculation we went over, where you take your respiratory rate and find how much time for each breath, and then subtract your inspiratory time to get expiratory. Thanks. Volume is good. Yeah, pressure regulated volume. Wow, Mohammed. Okay. Yeah, ventilator. Respiratory NP. Awesome. Also, I think Shrilu had a streak there too, so good job, Shrilu.
I cheated, guys. I have Dr. Jafari as my attending, so I apologize in advance.
So far. So yay, Shrilu and Victoria. Okay. All right, so let's get out of this. Okay. And any questions or feedback? As this is the first session, please just throw all of your thoughts at me.
Don't be shy. There's no question too complex or too simple for this session. This is what we want. We want to know, how do you feel? Like, how did you process the information? Was it helpful? Was there anything that didn't make sense? We would like to hear.
You guys did a good job. Nancy, you simplified a very complicated topic very well. So good job. My question to you, Dr. Jafari, is that how long does it normally take med students / residents to get to a comfortable place? Not that they're going to be experts like you anytime soon, but comfortable place.
Well, first of all, I would say I don't consider myself an expert. I still, from time to time, just to give you a perspective, if I have a very complicated patient, my training, my background is not in pulmonology, and people who get really good at knowing pulmonary physiology are usually pulmonologists or anesthesiologists. I still, from time to time, if I have a patient that I cannot figure out their ventilator settings or why their interaction with the ventilator is not the way I want it to be, I would just text my mentors and attendings from fellowship and say, hey, this is the patient. What would you have done? And there's always this gradient, and this is just purely a function of experience. But to give you a more straightforward answer to a question, I think that to feel comfortable as a med student to be present in the rounds and contribute, you should really focus on this lecture, plus hopefully the next lecture that Nancy will put together for how to allow this interaction between the patient and the ventilator to be as smooth as possible, with the combination of sedation and the optimizations that you can do on the ventilator. At least for the function of the rounds, the medical student, the level of the medical student should be able to, he or she should be able to go into the room, take a look at the ventilator, abstract information such as the vent settings, how the patient is interacting, what the patient is actually receiving, because Nancy was mentioning it over and over again. And a few important things such as plateau pressures in someone who has really non-compliant lungs, or peak airway pressure in someone who is having a reason to have high airway pressures. That would be, I think that would be a very good starting point for med students to feel comfortable with the ventilators. Remember, the ventilators are essentially a glorified computer plus an air compressor and some inlet oxygen and some sensors. That's all there is. I know it looks terrifying the first time that you're trying to interact with it, but that's all there is. And when you think about it in those terms, I think it's much more comfortable. It's much more easier for you to figure out what you need to know and how to make plans, hopefully, for managing the patients on the ventilator, which would be, I think, realistically the next step in your training, usually for more junior residents. Did that answer your question, Mohammed?
Yeah, thanks.
Any other questions?
Or any feedback too, if you guys like Zoom, if this was a good link.
I guess I can ask a question. Does anyone know? So Nancy was saying that SIMV will deliver some normalized breaths that the machine decides on, and then will support the patient through the ventilation when they're doing the work of breathing on their own. How does the machine interact with the patient if the patient is tachypnic? So remember the example that Nancy showed you had a respiratory rate of 15. What if the patient is breathing at a rate of 30? What would happen? Can anyone guess? What will happen to the breaths that the machine is planning to give? How would those 15 breaths would be delivered? Any takers?
Would they not be delivered since they're already automatically being triggered by like flow or like pressure?
What do you mean? Clarify.
Well, like you're mentioning that like the machine can sense if a patient's taking a breath based on things like flow or pressure, but if the patient doesn't breathe, it can breathe for them if it's been a certain time has elapsed based on the respiratory rate that's set.
Mm-hmm.
So if you're breathing fast, you just won't get those ventilator initiated breaths. You'll just get assisted breaths. That's what I'm guessing.
Okay, good guess. But I think you're touching on a very important point, and that is that what the machine does, it essentially samples the past performance in aliquots. So it looks at the past 10 seconds and decides that if you set the respiratory rate at 18, so it averages to 3 breaths per 10 seconds. And if you're taking all those 3 breaths in the first 10 seconds, then the machine would use the machine delivered breaths for those 3. And then it continues to do so until for the past 60 seconds, you already have taken all your 18 allotted ventilator breaths. And then if past that, let's say it's second 45 and you're already at the 18 and now you still want to breathe, you're awake. What the machine does is for the rest of them, the machine tries to give the pressure support ones. But over time, this actually averages because the machine doesn't look at the whole minute, but it only looks at 10 seconds at a time. So for example, it knows that I kind of have to expect 3. But if even in 10 seconds, you're taking 4 breaths, it only triggers 3 of them, gives the 3 of them as a patient ventilator initiated one. And for the 4th one, just gives you the support for the pressure support component. It just goes to emphasize the diagram that Nancy showed you that on a ventilator, when the patient is on SIMV, it's kind of this one. it's kind of a mix of both. So if you look at the pressure curves, you see both of them kind of in a mix with each other. SIMB is, I mean, I'm biased against SIMB because I was raised in the era of PRVC, but SIMB is a relic of the time that the best the ventilators could do was to combine two fairly simple modes. There are RCPs actually on this done to see if this is a more comfortable ventilator setting that allows for weaning the patients off the ventilator, and it hasn't shown any benefit. So in other words, you could go from assist control to pressure support and then take the breathing tube out. There are still a lot of intensivists that swear by SIMB, and they would still put the patient on SIMB, but before going to pressure support or extubation. It's just not part of my practice.
Okay, so just to clarify, so if the patient were to KIPNIC, the machine would still kind of do its own calculations and try to give both types instead of just converting all the way to
yes,
support.
yes, but it does it depend on the machine and the model. It does it in not the whole minute, but shorter spans of time. So it looks at the last 15 seconds or 10 seconds, and it continually averages. Questions? Anything that didn't make sense or was maybe a bit too complex? So I can expect all the med students rotating with us through SICU to be able to give us the vent settings, the plan manage. I'm kidding. As long as you can, as long as you can look at the ventilators and not be afraid, I think that's a very good starting point. I encourage you to go and ask your more experienced team members to help you get comfortable with the ventilators. They can be a bit scary, but they're very important. They're the kind of the, I mean, if there's anything that showed the world the value of ventilators and knowing how to deal with them is the coronavirus pandemic. I learned a lot. We have learned a lot using ventilators to manage these patients. But going forward, I think there will be serious questions as to how much time it should be given to teaching not just med students, but anyone who will come into contact with healthcare has to know about the ventilators. Because we had periods of time that we just didn't have enough intensivists, and we would have people from vascular surgery or thoracic surgery trying to help in ICUs taking care of these patients who are invariably intubated and needing a lot of ventilator support through the machine. And once you get into that territory, you need a lot of background information. It's not something that you can teach in like a 1 hour slide.
If nobody has any more questions, I'm going to stop recording.